As you know, it's important to me that the supplements I recommend and use are of the highest quality. That's why I stock the Protocol for Life Balance product line at my online dispensary, drhoffman.com/Protocol for Life Balance. Protocol for Life Balance offers a wide range of professional-grade products using ingredients backed by strong scientific research, including a suite of supplements specifically designed to support neurological health and cognition: Coggumin SLCP, Magtine, phosphatidylserine, and Brain Regain. Coggumin SLPC is curcumin optimized to penetrate the blood-brain barrier, where it helps protect brain tissue. Magtine may support healthy cognitive function, learning, and memory. Phosphatidylserine supports neuronal membrane fluidity, promoting cognitive function and mental acuity. And Brain Regain is a broadly useful herbal health aid that may be advantageous for supporting healthy cognitive performance. For more information and to order, just go to drhoffman.com/Protocol for Life Balance. That's drhoffman.com/Protocol for Life Balance. Protocol for Life Balance is an A-rated GMP manufacturer of premium dietary supplements.
Welcome to Leyla Muedin here on the Intelligent Medicine Podcast. Thank you for joining me. I'm your host, Leyla Muedin. I'm a registered dietitian nutritionist here in New York City. If you'd like to email me with questions, topics of interest that you'd like to hear me weigh in on, that email is questions@drhoffman.net. That is questions@drhoffman.net. You know, the importance of all of our vitamins and minerals are micronutrients, as they are called. We need to be on the alert for drug-induced magnesium depletion. This is coming out of holistic primary care, but the original paper was published in the New England Journal of Medicine. This is actually from July of 2024, but it's really worth getting into here because it's concerning. Be on the lookout for drug-induced magnesium depletions. That's one of the major messages from a comprehensive new paper found on the clinical impact of magnesium deficiency, which was recently published, New England Journal of Medicine. Many of the most widely prescribed drugs, including diuretics, proton pump inhibitors, PPI, Nexium, Prilosec, those are some of the PPIs, and certain antibiotics can cause magnesium wasting. Given how many people are on one or more of these drugs, it is likely that a large segment of the global population have iatrogenic magnesium deficiency. Iatrogenic meaning medically induced magnesium deficiency, from the drugs you're taking maybe. Now, most physicians, they don't routinely evaluate magnesium status. They should, according to the researchers, because they say clinicians should be more attuned to the importance of magnesium. Apparently, there are significant consequences. Quote, magnesium is a vital but poorly understood electrolyte in clinical medicine. It's often not measured as part of routine electrolyte screening. Hypomagnesemia, that's low magnesium, is often asymptomatic, but this does not mean that it's inconsequential. Magnesium deficiency is associated with and may play an etiological role in a host of cardiovascular, metabolic, and neurological problems. This is true. It is common among hospitalized patients and is predictive of prolonged ICU stays. Deficiency is particularly problematic for the heart and the vasculature. Researchers point out that low magnesium predisposes people to electrical irritability and arrhythmias, including atrial fibrillation, long QT syndrome, among other things. It is also tied to endothelial dysfunction, increased vascular tone, and vascular fibrosis. And there is a wide prevalence. The researchers say the paper does a thorough synopsis of the state of the science on magnesium deficiency, its causes and mechanisms, clinical impact, and the best strategies for detecting and remediating the problem. Pharmaceuticals are only one potential cause of magnesium deficiency, but they are a very important one because so many people are taking medications, right? We're talking mostly prescription medications is what they're alluding to here. And most people over the age of 50, 60, and they're getting younger and younger. People in their 40s are being put even younger than that, especially something like a PPI, an antibiotic. It's a problem. The authors acknowledge that the precise incidence of drug-induced deficiency is not really known. It's not something for which practitioners are routinely screening. And in the published epidemiologic studies of the subject, there's variability in diagnostic criteria and reporting methods. Objective numbers representing general populations are hard to come by. Now, that said, drug-related hypomagnesemia, low magnesium, has a prevalence of between 7 to 11% in patients admitted to hospitals for any cause. Some estimates are as high as 20% among inpatients, depending on the population studied and the criteria used. So again, magnesium deficiency is particularly problematic for the heart and vascular. It predisposes people to electrical irritability and arrhythmias, including AFib, long QT syndrome, something called torsades de points as well. Among outpatients, the estimate is that between 2% and 4% of all people are suffering from drug-induced magnesium depletion. This is likely an underestimate, and I believe that's true. I'm going to elaborate in a moment. But even if we assume that 4% is correct, that's still 13.7 million Americans potentially at risk. So they're talking about people who are low in magnesium due to the medications they're taking. But I'll tell you, most people are low in magnesium due to the stress in their lives, poor diet, especially sugar. Alcohol also reduces magnesium as well. So there are a lot of reasons for magnesium depletion. They're talking here about PPIs, proton pump inhibitors, diuretics, which, let you lose excess water. People with kidney issues, people with high blood pressure are often given diuretics. And they're pointing to PPIs and diuretics as the culprits. Among long-term PPI users, those of you taking Nexium, Prilosec, Acifex, Protonics, omeprazole, prevalence is roughly 20%. That's because PPIs alter the pH of the gut lumen, which adversely impacts intestinal magnesium absorption. Now, this effect is both dose and duration dependent. It's a scary thought, given that nearly 25% of all adults worldwide are taking PPIs, according to a 2023 global study of prescription drug use. The U.S. and other industrialized nations are clearly overrepresented in this survey, but general global trend is clear. PPIs are consistently among the top most prescribed drug classes. So, what are some symptoms? First of all, let's get into diuretics, because diuretics are similarly problematic. Some researchers estimate that between 25 to 30% of people taking loop diuretics are magnesium deficient. For those on thiazides, the estimates range between 25 and 30%. According to data gathered by biopharma industry analysts at IQVIA, there were roughly 82 million diuretic prescriptions in 2022. Aminoglycoside antibiotics such as gentamicin also cause magnesium wasting. Though antibiotic use in general has, thankfully, declined in recent years, they are still among the most widely prescribed pharmaceutical classes. So the researchers note that most cases of drug-induced low magnesium are explained by renal magnesium wasting. That means any drug that substantially impacts kidney function could lead to magnesium depletion, right? So how do we detect magnesium deficiency? First of all, let's talk about some of the symptoms of magnesium deficiency. I'm going to go down a list here. Muscle twitches and cramps, irregular heartbeat, osteoporosis symptoms, numbness and tingling in the extremities, fatigue and weakness, nausea and vomiting, a loss of appetite, constipation, headaches or migraines, brain fog, memory deficits, mental disorders, and depression. So what are the causes? Inadequate dietary intake, maybe water purification, soil depletion, long-term use of diuretic therapy, chronic diarrhea, excessive exercising, high alcohol consumption, age, being elderly, all of those. So the standard approach to assessing magnesium status is simply to measure total serum magnesium. Quick, it's an inexpensive way to gauge short-term changes. Keep in mind, the vast majority of the body's total magnesium is within the cells. In fact, less than 1% of all magnesium is in circulation. That's why even when you get a serum magnesium level, it doesn't give the true picture. So consequently, serum levels do not reliably reflect magnesium stores in tissues. Further, serum levels can be affected by a range of confounding factors like low albumin, hemolysis, and a presence of anticoagulants in the tubes where the blood is collected. That said, serum measurements are really the only practical objective test for clinical use. So, according to generally accepted guidelines, normal serum magnesium levels in healthy adults range from 1.7 to 2.4 milligrams per deciliter. Hypomagnesemia, low magnesium, is defined as levels below 1.7 milligrams per deciliter. But don't rely on serum levels in isolation, the authors say. Look at blood measurements in the context of a patient's overall health, symptom patterns, clinical history, diet and lifestyle. Most cases of drug-induced low magnesium are explained by renal magnesium waste. So any drug that substantially impacts kidney function could lead to magnesium depletion. Controlled depletion, repletion studies in metabolic units have shown that even though serum magnesium concentration may be normal, intracellular stores can be depleted. Therefore, the use of blood magnesium levels alone, without consideration of dietary magnesium intake and urinary loss, probably underestimates magnesium deficiency in the clinic. That is their claim. Yeah. While extreme deficiency will usually make itself known through symptoms like muscle cramps, tremors, seizures, arrhythmias, palpitations, or metabolic changes like low potassium or low calcium. Bear in mind that most patients who are mildly low in magnesium with levels in the 1.5 to 1.7 milligrams per deciliter range will likely be asymptomatic. But this does not mean they're not at risk. And pay close attention to those who have diabetes. The researchers point to several studies showing low magnesium is common among type 2 diabetics. In this context, kidney magnesium wasting, renal magnesium wasting, and increased albumin binding in the blood are probably the causes of hypomagnesemia. Magnesemia. Insulin resistance results in decreased renal magnesium reabsorption and increased loss of magnesium in the urine. Insulin resistance being associated with type 2 diabetes or anywhere on the metabolic abnormality continuums, starting with, metabolic syndrome, pre-diabetes, all the way to diabetes. Also be aware that alcohol use is a factor in this equation. Magnesium depletion is the most common electrolyte abnormality associated with chronic heavy drinking. Underlying mechanisms include decreased magnesium intake in malnourished people, increased gastrointestinal loss, think diarrhea, right? And losing magnesium in the urine due to alcohol-induced renal tubular damage. Magnesium deficiency in heavy alcohol users is often associated with liver dysfunction, and it signals an overall poor prognosis. If someone's history, physical exam, symptom patterns, lifestyle, prescription drug use, and blood work lead you to suspect a serious magnesium deficiency, it may be worthwhile to have tests done like a 24-hour magnesium excretion, maybe fractional magnesium excretion. I'm talking to practitioners now, and magnesium loading protocols that can help differentiate between a gastrointestinal magnesium loss and a magnesium loss due to impairment in kidney function, right? So we also need to be aware that magnesium deficiency is often accompanied by other nutrient and electrolyte deficiencies. Low potassium is common in people with low magnesium and vice versa. The deficiencies co-occur in 38 to 40% of patients. Long-standing magnesium deficiency impairs repletion of cellular potassium, and it amplifies renal potassium loss, kidney potassium loss, by promoting potassium excretion in the collecting duct. See how magnesium kind of controls that a little bit? The fact that if you're deficient in magnesium, it messes with the other electrolytes like potassium. So, that said, refractory potassium repletion is sometimes linked to magnesium depletion. This is particularly true in people with congestive heart failure, those who are taking a cancer drug called cisplatin, and those taking diuretics and it can only be corrected after the magnesium levels have been normalized. So the interplay between magnesium and potassium is very interesting. It's very involved, right? So low calcium levels are also linked to low magnesium. That's because magnesium deficiency suppresses the release of parathyroid hormone, PTH, which consequently decreases the kidney sensitivity to PTH, leading to reduced reabsorption of calcium in the kidney. Something researchers proved more than 40 years ago. Again, when low calcium co-occurs with low magnesium, it's nearly impossible to fix without first normalizing magnesium levels. So how to restore it? So they say there are no clear and widely accepted treatment guidelines for reversing low magnesium, and they say approaches depend largely on the presence and severity of clinical manifestations. Okay, mild low magnesium is managed with oral supplements. Many magnesium preparations are available, and they have variable absorption rates. They contend that the most effectively absorbed forms are, magnesium glycinate, gluconate, maybe aspartate, citrate, rather than things like magnesium oxide or carbonate. Diarrhea is a common side effect of oral magnesium supplementation, as many of you may know, which may pose a challenge for oral replacement. It is definitely something that patients need to be educated about. So, this is very important. You gotta be careful of prescription drugs you're taking if they're adversely impacting your magnesium levels. I want to thank you for joining me on another edition of Leyla Muedin. This is Intelligent Medicine.
I want to thank you for listening to the Intelligent Medicine Podcast. Follow us on Apple Podcasts, Spotify, Amazon Music, or your favorite podcast app, and get new episodes automatically downloaded every weekday. And please give us a rating and review. It truly helps new people discover intelligent medicine. The Intelligent Medicine Podcast is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or materials linked from this podcast is at the user's own risk. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have and should seek the assistance of their healthcare professionals for any such conditions. Finally, please visit drhoffman.com and discover everything Intelligent Medicine has to offer, including frequently updated, unbiased health news and fully vetted product and supplement recommendations.
This is Leyla Muedin, registered dietitian nutritionist. I maintain a private practice and see patients regularly. If you require a nutrition consult with me but live out of town, there's no need to travel to New York City. I have telephone and telehealth consultations with clients from all over the country. Please visit drhoffman.com for more information. And to set up an appointment, call 212-779-1744. That's 212-779-1744. I look forward to being a collaborator in your healthcare.